ان انت لما تطلع لك حاجة يعني حاول تعود نفسك على هذا الاتيتيود، انك الاول تقول اسم الفحص وبعدين تقول ايه اللي موجود وبعدين تقول التشخيص. و هنمشي بالترتيب من كده هوت، وبعدين اجابات جماعية وبعدين انا اللي هجاوب. طيب دوت اول حالة. اتفضل. الأول في without contrast أول صورة، وبعدين arterial phase وبعدين portal phase.
without contrast في classification.
تمام.
بعد كده في arterial phase في fluorescence enhancement.
أيوه.
وفي focal lesion وفي fluorescence enhancement وفي central necrosis.
أيوه. نعم.
وفي early wash out في البليد phase أو في
البورتال phase. أيوه. تمام. يبقى ماله؟ قلت ايه؟ ايه؟ فايبرولاميلر. طيب يبقى احنا عندنا في الوزاوت كونتراست عندنا كالسيوم، وبعدين في الويز كونتراست عندنا arterial enhancement ووش اوت. عندنا تيومر كبير جدا involving most of the right hepatic lobe، والأهم من كده إن المريض ده هو ما عندوش negative tumor markers وما عندوش previous history. عليكم السلام ورحمة الله وبركاته. of liver problems، زائد السن، إن السن بتاعه صغير. طبعا ما فيش مانع ابدا ان الهيباتوسيل كارسينوما تكون موجودة في سن صغير اذا كان في سيروسيس، لكن لما تجتمع هذه الامور big tumor size، ما فيش cirrhotic manifestations في الليفر، central scar with calcium، and this is the diagnosis of fibrolamellar hepatocellular carcinoma. واحنا قلنا ان الفايبرولاميلر هيباتوسيل كارسينوما بتختلف عن الاتش سي سي العاديه في 7 حاجات. الحاجه الاولانيه ان ملهاش علاقه بالسيروزس. الحاجه الثانيه ملهاش علاقه بالالفا فيتوبروتين. الحاجه الثالثه بتحصل في سن صغير. الحاجه الرابعه البروجنوزس بتاعها افضل. الحاجه الخامسه the tumor at the start is very big. الحاجة السادسة ان هو عنده central scar and the presence of calcium. كل الحاجات دهيت بتبقى in favor of the fibrolamellar type which is more better عن ال original hepatocellular carcinoma من ناحية البروجنوز. اتفضل يا باشا. ما يهمكش سي تي without contrast انهي حته. طيب هنا طبعا يعني في العادات العاديه ممكن تقول شكلها ومتهيألي والكلام ده كله، بس انا ما انصحكش انك انت تقول هذا الكلام في الامتحانات. خلاص. الاول and this is CT scan of the pelvis without intravenous contrast ولا oral administration of contrast, and the patient is 45 years old وعنده leukocytosis and acute pain in the right lower abdominal quadrant، يعني في right iliac fossa. Then you see there is a lesion اللي هو almost at the site of the appendix, and there is a calcified appendicolith أو phlebolith، سميها زي ما تسميها، and the appendix is filled with fluid ودوت معناها when if you look carefully there may be some stranding of the fat around the appendix, then you know that you are dealing with the case of acute appendicitis. Okay, اسمها
axial CT with a contrast عندي multiple focal lesions موجودة في السبلين. Daily peripheral enhancement.
Okay, and this is in post-contrast CT scan of the upper abdomen after oral and intravenous contrast administration. The spleen is enlarged and it is the site of many variable sized focal lesions, and the lesions are solid. بالرغم انهم they look like in the cystic, but if you look inside the internal texture of the lesions you will see that they are solid, and you may suspect minute focal lesions here in the liver. Then solid lesions in the spleen, the most common is lymphoma. In the primary lesions occurring in the spleen are uncommon. The secondary lesions are also uncommon, and this may be due to lymphoma or metastasis. And if there is a positive history of primary malignancy, then you think of metastatic deposits, but in absence of this history, you consider the possibility of lymphoma, which is more common. Then okay.
Abdominal CT.
Yeah.
With contrast.
Okay.
Well-defined hypoechoic mass lesion in the liver subcapsular.
Okay.
عاملة bulging للكبسول.
Okay.
Mostly in the right loop of the liver.
Mm-hmm.
Okay. After injury,
Mm-hmm.
mostly hematoma.
Hematoma. Okay, and this is a contrast enhanced CT scan of the abdomen at the level of the liver in a patient with hematuria and right upper quadrant pain after a trauma to the abdomen in a football match, and there is a hypodense collection at the border of the liver along the anterior aspect and also the lateral aspect. And you know that lesions occurring after trauma should be considered as hemorrhage. Thank you very much. And the hemorrhage in the abdomen is not like the hemorrhage in the brain. The hemorrhage in the abdomen, if it is not seen in the first 24 hours, it will appear like fluid. Then considering the history of trauma and there is a hypodense collection along the surface of the liver, you should consider this as subcapsular hematoma. Then you look carefully to the rest of the organs, and you look to the spleen, it's commonly injured, and also you look to the parenchyma of the liver if there is lacerations or not. There is no laceration, these are the portal venous radicals, and this hematoma conforming to the hepatic contour, you should consider the subcapsular hematoma. No, this is an arterial phase. Then this should be branches of the hepatic artery, and the hypodensities will be the branches of the portal vein.
بس الهايبردنسيتي مش ممكن تكون intrahepatic leak من الكونتراست.
الجمجمة فيها حتة هايبر أبروتش.
حلوة أوي هايبر أوكوك، لكن مش مشكلة. Okay, then ما فيش leak from the vessels in the liver without laceration. يعني لازم الأول يكون في injury of the hepatic parenchyma, then you can see the leakage of contrast. This is very common in the spleen, and especially in the shuttered spleen. Then you see the vessel is leaking the contrast material. But in the liver, there should be a major injury first, وبعدين تلاقي the contrast materials coming out from the artery. Okay? طيب. ARCB and MRCB. Okay. Okay. This is the common bile ductum. Okay, and this is the pancreatic duct. Then this is the duodenum, and this arrow points to this stone at the neck of the gallbladder. قلت ايه؟ Merizi syndrome. Then in cases of Merizi syndrome, قلنا the stone is impacted near the neck of the gallbladder, and it will initiate an inflammatory reaction which will compress the common bile duct or the common hepatic duct, and this will lead to intrahepatic biliary radical dilatation and some sort of jaundice بالنسبة للمريض. والليلة ديت كلها على بعضها اسمها ميريزي سيندروم. هو الفيلينج ديفكت.
الفيلينج ديفكت الصغير ده؟
لا، الكورومبا دي.
اللي هي
يلا يا ابوي، بتضحك عليا اهي. axial CT of the abdominal أو abdomen and the pelvis. Showing multiple focal lesions in which organ? In the abdomen, in the peritoneum, and this is not the level of the liver or the spleen, and you see multiple cystic lesions in the peritoneal cavity. Okay, and these lesions with some internal septations, and you remember ان احنا قلنا ان في بعض الناس اللي عندهم hydatid cyst في الليفر especially يعني في الليفر it can rupture والدوتر cysts will be scattered in the abdomen وتكبر وتعمل multiple hydatid cysts اللي احنا بنسميها peritoneal echinococosis أو hydatidosis و most of the lesions will show the criteria of the hydatid disease, including internal cysts or floating shadows or marginal calcification. Plain X-ray of the abdomen. Plain X-ray of the abdomen showing dilated transverse colon. Toxic megacolon, when the transverse colon is more than 6 centimeter in diameter, and there should be lots of ulceration. ايه صرخ شوية. ها؟ large intestinal obstruction. الاستومك ماله؟ ماله؟ طيب, and this, if you look carefully, you can see the wall of the colon, and this is an indication of pneumoperitoneum. الساين اللي احنا قلنا عليها اسمها the regular sign. If you see the wall of the stomach, or if you see the wall of the colon or the small bowel, then there should be air inside the colon and air outside the colon. And air inside the colon is normally found, but outside the colon is diagnostic of pneumoperitoneum, and this is known as regular sign. من ايه ده سي تي ولا ام ار؟ سي تي. CT of the abdomen and the pelvis 3D reconstruction بالالوان الطبيعيه. multiple foreign body. وايه اللي عرفك ان هو كوكايين يعني بالذات يعني طلع كده؟ طيب ايه يعني عرفت ان هو كوكايين. دولت تمنهم $40,000 ايام الدولار ما كان يعني قبل التعويم. دي طبعا وسيلة من الوسائل المعروفة في تهريب المخدرات، ان الناس تحط البتاع كده، طبعا بيكون عليها بلاستيك وحاجات زي كده عشان ما تبص، ويدخل بيها في المطار عادي جدا وما معهوش حاجة خالص كده اهوت، وبعدين يروح يطلعها بعد كده. المهم الحكاية دي مشهورة قوي، ومشهور منها حاجات كتيرة جدا على الانترنت. بلين جيست اكس راي وزباريوم. انت قلت كده صح؟
انا مش بلين، باريوم.
وهو شيست ولا شيست ولا ايه؟
لا فور ذا
abdomen. اوكي، يعني دوت an examination of the abdomen with barium meal follow through. تمام كويس. فين الديزيز؟ قلت فيه هوا ده يعني. طيب لا، وانا احنا ما بنشوفش الاديجنز على فكرة. انا لو كان في يعني عشان نعرف اذا كان في اديجنز ولا لا لازم يكون في intestinal obstruction.
هذه ممكن
كان ما هو هيقول يا جماعة البرازيت مش منتشر في اليمن ولا ايه؟ اكيد منتشر. طيب انهي برازيت فيهم بقى؟ ها؟ الاسكارس. طيب ما عندك 3 برازيتس في الانتستين اللي هم الجارديا وده ما بيتشافش، والتينيا ودي طولها 6 متر، والاسكارس اللي هي طولها 30 سنتي.
يعني ايه الاناتومي؟ يعني اللي فوق ده جوجنال لوب
ايوه ده الانتستين سمول باول بروكسيمال جيجينال لوبس، وده الإيليوم، والإيليوم مليان بقى بارازايتس، وفي البارازايتس اللي بالطول دي زي واحدة هنا وفي واحدة هنا، لكن دولت كبشة كده. ودايما الاسكارس بيحب يعيش في جماعات، يحبش يعيش لوحده. وواحدة من الحاجات المشهورة الكومبليكيشنز ان يعمل انتستينال اوبستراكشن، او طبعا يعمل مال ابسوربشن لان هو بياكل كل الاكل اللي بياكله المريض.
يعني هو اللي مخلي الإيليوم دايليتد كده وفي لاست باترن طب الإيليوم منين لفين؟ يعني هو عشان
ماشي. الإيليوم دايليتد عشان متعبي بالاسكارس.
بس هو كده شورت سيجمنت ولا هي حته من الإيليوم اللي افكتد بس والباقي
لا، ما الاسكارس طبعا بتتمشى في الانتستين، ساعات ترسي على مكان يكون بالنسبه لها كويس، سواء كان في البروكسيمال او في الديستال، ويتجمعوا زي الجماعه الضخمه جدا ديت كده.
يعتبر ده ترمينال إيليوم؟
يعتبر ترمينال إيليوم لان بعد كده الكولون هيكون واسع.
يعني هو زائق السيكم فوق
لا، هو بس ممكن عشان ده برق ميل فول ثرو فما يكونش السيكم مالي كويس يعني دي. طيب اتفضل يا باشا. ايوه.
في سيمنج وول انتستين او في ستومك.
ايوه.
ممكن يكون
carcinoma. Okay, and this is contrast enhanced CT scan of the upper abdomen, and they see focal mural thickening of this is the region of the gastric fundus at the junction with the esophagus, and how at the gastroesophageal junction, and there is significant mural thickening of this part. ودوت زي ما انت قلت كده ممكن يكون ديوتو كارسينوما، ممكن يكون ديوتو ليمفوما، او ممكن يكون ديوتو ميتاستاسيس اذا كان في برايمري مالجنسي. وطبعا في حاجات تانية في الاستومك زي الجست تيومر مثلا وزي الكارسينويد ممكن يعملوا مناظر قريبة من كده، لكن على رأس القائمة بلا منازع هو الادينوكارسينوما of the stomach، واللي هي ممكن involve the distal part of the esophagus. كما لو كانت موجودة in the pyloric canal it can extend to the proximal part of the duodenum. Okay. CT of the pelvis after intravenous contrast injection. في ليجن ولا مفيش؟ في ليجن. فين هو؟ and this is the site of the pathology. هنا اهوت نهاية الريكتم and this is the sigmoid colon، وهو في الحتة بتاعت السيجمويد كولون مع الديسندنج. وعندنا التلاتة كرايتيريا المشهورين بتوع diverticulitis. نمرة واحد ان يكون في divertically containing air. نمرة اتنين ان يكون في thickening of the affected colonic wall. نمرة تلاتة ان يكون في stranding of the pericolic fat. وهم دولت التلات حاجات اللي انت بتشخص على اساسهم الايه الاكيوت diverticulitis of the colon. اوكي. Contrast enhanced CT of the chest, arterial phase, axial and coronal reconstruction. الأورطة ده الأورطة، ده البلمونري، ودولت البرانشات اللي طالعة من الأرش. قصدك على دوت ولا ده الليفت مين بالمونري ارتري، وده الحته الاخرانيه من الاورتيك ارش، وفي نوت جزء من الكاردياك شادو. لكن this is the esophagus which is markedly dilated، مليان ميه وفي air fluid level أكاليزي. Then the esophagus at the terminal part عندنا mural thickening وعندنا tapering towards the gastroesophageal junction. اللي بيعمل كده حاجات كتيرة، اللي هو reflux esophagitis والأكاليزي of the cardia والcarcinoma of the distal part of the esophagus. وطبعا في حاجات اللي بتعمل ستيزيس ان الاسوفجاس زي السكليروديرما وخلافه. لكن اللي بيخلي الاسوفجاس اهلا ست حنان واسع قوي كده وفي اير فلويد ليفل، هو دوت الايه الاكاليزيا اوف ذا كارديا، هي اللي بتدي فرصه للاسوفجاس ان هو يدايليت وان يكون في اير فلويد ليفل. لما تشخص الاكاليزيا اوف ذا كارديا ما تنساش تبص على اللنج عشان موضوع الاسبيريشن نمونيا مهم جدا في الناس اللي عندهم الاكاليزيا. ايوه وايه
دكتور ولا نتكلم كلنا؟
لا ولسه بالدور شغال وهيجيلك الدور ما تخافش. يعني ايوه ايوه تمام. الليمفوما then عندنا focal lesions in the liver and the spleen. The lesions are solid, they are not cystic, they are hypodense. ما اقدرش اقول اذا كانت enhanced ولا لا الا لو كان عندي بري كونتراست سكان عشان اعرف الدنسيتي بالظبط قد ايه. لكن كل اللي يهمني هو انها solid، ديت اهم حاجه في الموضوع. and these lesions are not containing fluid، الفلويد بيبقى عامل زي كده. then solid lesion in the spleen رقم واحد هو الليمفوما، وبالتالي هيكون اللي في الليفر برضو نفس الحكاية. and if this patient is known to have a primary malignancy ينفع طبعا يكون في السبلين metastasis، وكذلك في الليفر يكون في metastasis. ما اقدرش اقول اذا كانت هي انهانسد ولا لا الا لو كان عندي نون كونتراست وقارن الاتنين من بعض. لكن لا عمر الانهانسمنت ما يوصل لنفس البارينكما. في معظم الهايبوفاسكولار فوكال هيباتيك ليجنز بتبان سودا على الباك جراوند بتاعه الليفر، لكن الهايبر فاسكولار ليجنز بتنهانس في الارتيريال فيز اعلى بكتير قوي من الدنسيتي بتاعه الليفر. وبالتالي اذا كان عندي من غير صبغه اقول ان هما مش انهانسنج او انهانسنج، لو ما عنديش اقول ان هما هايبودنس فوكال ليجنز في الليفر. نعم ايوه دوت نعم ده بريك داون اللي هو الحته الصغيره. بما ان الليجن بيوصل حجم كبير فسهل قوي ان هو يكون فيه. مين اللي عمل طول عمرك انت مشاغب كده؟ طيب مين اللي عليه الدور؟ ايوه. مالتيبل بولوبوزيس قلت. طيب الاكزامينيشن دوت هو سبوت فيلم عند terminal ileum. This is the ascending colon والترانسفيرس، ودوت جزء من الإيليال لوبس، والحتة ديت هي اللي فيها المشكلة اللي هي بتاعة التيرمينال إيليوم. وعندنا linear filling defects كده متشعبين. البوليبس طبعا لازم يكون كور filling defects كور، لكن دهوت خطوط. انت بشاور لي على اي كورة منهم؟ ها دي هنا؟ لا بس دولت تقدر تعتبر ان هو خط بس مقطوع بالعرض، فاذا كانوا هما خطوط يبقى ايه ماله؟ بص هو طبعا البارازايتس في الانتستين في الوقت اللي احنا فيه ما بقتش كومن، لكن احتمال كبير مش عشان الانتي بارازيتيك تريتمنت، لكن احتمال عشان الناس اصلا ما بتاكلش يعني. فالبارازايت هيعمل ايه؟ قال لك لا انا اشوف حته تاني غير البلد الفقر دي. لكن طب انت بتشوفهم ليه؟ عشان في ناس مخبيه الافلام دي تحت السرير زي ما انا قلت لك. اتفضل.
بس الاسكارس مش بيكون في النص كده.
بس مش كلهم يعني. اذا انت عامل فيلم سبوت مكبره على الاخر خالص، بتلاقي الاسكارس وبلع بريم كده في نصها از فيلينج ديفكت. لكن دوت اذا كانت موجوده فدي علامه كويسه، اذا كانت مش موجوده ما يمنعكش برضو انك انت تشخص الايه الاسكارس. طيب اتفضل. CT scan of the abdomen, enlarged liver, والايه؟ قلت ايه اخر كلمة؟ multiple spleens. طيب and this is post contrast CT scan of the abdomen. الليفر is not on the right and not on the left، اللي احنا سميناه situs ambiguous. والكرة مليانة مية ديت وفيها هواء and this is the stomach. والكور الصغيرة ديت these are the spleens اللي هو بوليسبلينيا syndrome. واول ما تشخص بوليسبلينيا لازم تشوف الاي في سي، لانه هو غالبا ما بيكونش موجود وبيكون في واحد مكمل مكانه اللي هو الازيجوس او الهيمي ازيجوس. فالاول تحط ايدك على الاورطه، لو كان الفيسل المكمل تو ذا رايت يبقى الازيجوس فين، لو كان تو ذا ليفت يبقى الهيمي ازيجوس فين. يبقى في البوليسبلينيا بيكون الليفر في النص، بيكون ولا شمال ولا يمين، اسمه سايتس امبيجوس. بيكون الاستومك تو ذا رايت، وكذلك السبلين تو ذا رايت، بس في منه كذا واحد. وبيكون في interrupted IVC وبداله في azygous continuation او hemi azygous continuation. هاي ست حنان. لا نجاوب بس ست حنان. Ultrasound of the abdomen showing gallbladder with gallstone. اسمها acoustic shadowing. الانهانسمنت ده بتاع السيست. طيب يبقى this is the gallbladder and this is a stone بأمارة ان في acoustic shadowing posterior to the. طبعا if you appreciated that this gallbladder wall is thick, you may think that this is acute calcular cholecystitis. لكن ان حلو قوي بس ان احنا نقول ان في هنا gallbladder stone. اوكي نبتدي من جديد. اتفضل. لا في ناس جت ما جاوبتش لسه. انتوا ما جاوبتوش صح؟ طيب يلا اتفضل.
Abdominal CT.
ايوه
Mass liver.
ايوه
Answering wall.
ايوه
Clear over.
ايوه
Classification
ايوه
in wall.
ممتاز. And this is a CT scan of the abdomen showing a cystic lesion in the posterior segment of the right lobe, showing dots of marginal calcification. يبقى hydated. واحنا قلنا الhydated is diagnosed بثلاث طرق، يا اما كالسيوم يا اما floating shadows يا اما daughter cysts inside a cystic كبير. اوكي اللي جنبك جاوبت؟ ما جاوبت؟ ممتنع عن الإجابة؟ طيب اوكي. حد عاوز يجاوب؟ ها؟ في فلويد في البريتونيوم يعني اسايتس. طيب ايه كمان؟ زي ما يكون البنكرياس تخين شوية. ده البنكرياس. ها الايه؟ هو تخين؟ انت صدقت حنان؟ ده بنكرياس تخين، ده انيميك، ده بنكرياس مسلوع جدا. ما فيش هنا اي هيستوري اوف تروما. يعني ايه الفحص دوت؟ شكله بريم ميل كده ولا ايه؟ this is the esophagus and this is the stomach. مالها الاستومك؟ في marked narrowing of the distal part of the gastric body as well as the pyloric canal with irregularity of the wall. ارجع للCT هتلاقي thickened pyloric canal with irregularity of the wall and the lumen. التشخيص؟ لا كارسينوما الأول، كارسينوما الأول وبعدين يصير خير. ماشي. احنا قلنا قبل كده ان الليمفوما is diffuse lesion, the carcinoma is a focal lesion. الليمفوما is usually affecting most of the stomach. الكارسينوما distal in the pyloric canal. الليمفوما ما بتعملش obstruction، الكارسينوما بتعمل. الليمفوما مش بتinvade the surroundings، الكارسينوما بتinvade. الليمفوما الليمف نودز بتاعتها بتبقى bulky homogeneous، الكارسينوما بتبقى necrotic and small. طيب and this is gastric carcinoma. اللي هنا ده الهيد اوف ذا بانكرياس، وده superior mesenteric artery، وده superior mesenteric vein، وهنا هوت part of the duodenum دوت كده، وده بقية الانتستين على الناحية دي فيها جاستروجرافين. and this is the gall bladder. ممكن يكون الجدار بتاعها تخين شوية وفيها enhancement، قد يكون فيها كوليسيستايتس، وعندنا اسايتس زي ما احنا اتفقنا. نبتدي من جديد.
في multiple specific cycle.
يا ابني اسمه ايه الفحص؟
في axial CT with contrast, abdominal CT with contrast.
تمام.
في multiple specific cycle body and chest pancreas.
اوكي.
chronic swollen شوية بس likely chronic pancreatitis.
طيب, and then this is a CT scan of the abdomen after intravenous and oral contrast media administration, showing the pancreas in the body and the tail, numerous foci of calcification, and the pancreatic duct is irregularly dilated. When we have mentioned before in the only sign of chronic pancreatitis is the presence of calcium in the pancreatic tissue, and the second sign is irregular slight dilatation of the pancreatic duct, and both signs are present here. Okay. CT scan of the abdomen with intravenous. مفيش اور صح ولا ايه؟ طيب ايوه كولانجيو ولا كارولي. نعم. This is CT scan of the abdomen after intravenous contrast injection, showing irregular non-uniform dilatation of the intrahepatic biliary radicals, tubular and cystic. Then if you look in the porta hepatis, the common bile duct is not dilated, but one of the very important signs is the central dot sign. And the central dot sign is pathognomonic for Caroli disease. Cystic dilatation of the intrahepatic biliary radicals together with the central dot sign, which represents one of the portal venous radicals, and also the presence, there may be an associated some cystic changes in the kidneys. Then this is Caroli disease. And these are vessels due to portal hypertension. These are portovenous collaterals. Yes, the IVC is slightly dilated. And you know that the IVC is, the caliber of the IVC is controlled by the breathing. If you have big breaths, and then you may compress the IVC, and you have expiration, then the IVC will expand. All the veins in the body, except the intracranial veins, are controlled by breathing sometimes.
nothing significant to comment on.
No, what is significant is the presence of an intraluminal filling defect or total absence of the IVC. But even in the internal jugular veins and the superior vena cava are the same. You may see the superior vena cava is big, one of the internal jugular veins is big, and this is normal variation. Barium mean and follow through.
عندي المعدة أو the stomach عند
ده تفكير ولا إجابة؟ ده كويس برضه التفكير. يعني في الامتحان ما تفكرش بصوت عالي، يستحب فكر في سرك عشان هما بيبقوا بيتصنطوا عليك عشان يلتمسوا منك أي غلطة. Okay, and Asma قالت and this is barium meal, and in the barium meal there should be some opacification of the esophagus and the duodenum, no harm. But this is the lesion, and the lesion is in the form of a crater which is filled with barium protruding beyond the gastric contour. And we have said that the ulcer, whenever seen on FAS, it will appear as a loculus of persistent loculus of barium, but when seen on the lateral view on profile, it will project beyond the contour. Then if we decided that this is gastric ulcer, and we have to differentiate between benign and malignant, what do you think?
gastric folds رايحة ناحية الألسر.
Okay, and then the gastric folds are directed towards the ulcer. It's a benign ulcer, and this is right answer. This is the gastric folds are seen converging and reaching the ulcer edge, indicating that this is a benign lesion. Yes, and this is known as the incisura. When the ulcer is located on one curve, then there is a spasm and edema towards the ulcer on the opposite curve. This will appear like this. It's known as the incisura. There is no filling defect. Just you see that the stomach, this is the regular outline of the stomach coming like this. But if there is a filling defect, then you should see barium here, outside the filling defect. Okay. Good.
Axial CT abdomen with bone thrust. There is multiple size, hypoequic mass lesion.
Hypodense.
Hypodense. I think with the septation, internal septation, beside it.
With internal septations. Hydated. شاردين انطقطقوا هم كلهم. Okay. طيب, and then we have the CT scan of the abdomen and the pelvis after intravenous contrast injection. There are multiple focal lesions in the spleen and the big lymph nodes in the internal iliac group. Then if you look to the focal lesions in the spleen, and you see that this is not a fluid density. The fluid density is something like this in the renal bladder, for example, but here you can feel that there is some solid consistency within the focal lesions. And focal lesions solid in the spleen, you think of lymphoma, especially if you see bulky lymphadenopathy in the pelvis like this one, then the diagnosis will be lymphoma, whatever, it commonly will be of the non-Hodgkin type. CT on the abdomen, axial cut, without contrast. Calcification of the wall of the gallbladder. Porcelain gallbladder. Yes. أيوة, atheromatous calcification of the aorta. Then this is an uncontrast CT scan of the abdomen. There is no contrast in the aorta nor in the kidneys, and you see calcium dense calcification in the wall of the gallbladder, which is diagnostic of porcelain gallbladder or cholecystopathia chronica calcarea. And this is a precancerous situation with a 30% risk of malignancy in the urinary blood, in the gallbladder. MRI axial cut of the abdomen, T2 weighted image. ايه نورمال الليفر ولا الاسبرين هو اللي تعبان؟ الليفر. ماله الليفر؟ في سيست في الليفر. هيموسيدروزس. اوكي. Then احنا اتفقنا ان في T2 weighted image and even in the T1 weighted image you compare the signal of the liver and the spleen by the signal of the muscle. If the signal of the liver is more dark than the muscles, then you consider iron overload اللي هو hemochromatosis أو hemosiderosis. And this is the cystic lesions in the liver. Axial CT of the abdomen with oral and intravenous contrast media administration. Well circumscribed focal lesion in the liver showing peripheral nodular enhancement, most likely hemangioma. Okay, and this is hepatic hemangioma, cystic lesion with peripheral nodular enhancement. There are three types of hemangiomas in the liver: the flash filling hemangioma, which is less than 1.5 centimeter, the regular hemangioma like this one, and giant hemangioma, which is more than 6 or 10 centimeter in diameter. ده بلفيك اريا حنان. طيب ها ايوه طيب فين الهيموبيليتونيوم؟ يعني في بيرينفريك. طيب okay. And this is a contrast enhanced CT scan of the abdomen, and you see lacerations of the left kidney and the hypodense collection around the kidney representing perinephric hematoma. And we have said that grade 1 renal injury is just a contusion, and grade 2 renal injury is a superficial laceration not reaching the pelvic ileal system. Grade 3 is laceration deep reaching the pelvic ileal system. Grade 4 shattered kidney. Grade 5 vascular avulsion of the vascular pedicle. Shattered kidney, you can sometimes consider this as shattered kidney if there are multiple pieces of the renal parenchyma lacerated. Okay. Very meal. خلاص بريم ميل وخلاص ولا في حاجة تاني؟ defect in the duodenum هنا يعني؟
ايوه.
طيب يعني انت عاجبك الاستومك نفسها؟ طيب ليه تسيب الحمار وتمسك في البردعة؟ امسك في البتاع يعني الاستومك and then there is marked thickening of the gastric mucosal folds all over the gastric body and maybe in the pyloric canal as well. لكن this may be just a contraction in the duodenum and diffuse thickening of the gastric mucosal folds. There are a lot of differential diagnoses. Number 1, lymphoma. Number 2, hypertrophic gastritis. Number 3, menetrier disease. Number 4, Zillinger-Ellison syndrome. And there are also granulomatous gastritis, TB, sarcoid, and so on. And also you can include Crohn's disease of the stomach. Most of these lesions can produce this appearance, like the hypertrophy and thickening of the gastric mucosal folds.
Contrasticity of the axial and coronal.
Yeah. Okay, this lesion is outside the liver and also outside the kidney. This lesion, then it will be in the adrenal gland. And a big mass in the region of the adrenal gland containing fat and soft tissue. Yes, and this is myelolipoma of the adrenal gland. Why this is not a hepatic focal lesion? Because you can see the very clear margin separating the lesion from the liver, and you cannot see liver tissue along the posterior aspect of the lesion. And this is not a renal pathology because of the absence of the claw sign. Then in an adrenal lesion containing fat is myelolipoma, gross fat, I mean. Barium meal follows through. Crohn's disease. Yes, this is Crohn's disease. You should say that there is marked narrowing of some of the small intestinal loops with irregularity of the wall, and there is no evidence of fistulae مثلا or leakage of the barium outside the lumen, and the only lesion which can produce this appearance is the Crohn's disease. Barium meal. There is. قلت ايه؟ Okay, and this is double contrast barium meal. You can see that the stomach showing marked hypertrophy of the mucosal folds, and also there is a significant irregularity of the greater curve of the stomach with the mucosal destruction along the gastric body. This is the pyloric canal and this is the duodenal bulb. Then there is a significant part of the stomach which is missing, meaning that it is involved by a lesion, and this lesion should be of malignant nature and lymphoma or carcinoma. And he should say first that this is carcinoma of the stomach, because this is just a transient collection of barium. If it is persistent, then you may think of.
دكتور المباني pylorus والفيرست part اللي هو هتبقى نار كده.
This is the gastric outlet. بتبقى عاملة كده and it opens in front of the food bolus. Okay. Mass. Yeah. And what is the possibility of this mass? Babyloma. Okay, and this is ultrasound, and you see the gallbladder, and there is a lesion, and this lesion is not with acoustic shadowing. It is also not mobile, because if it is mobile, it should be here. And this is the mass adherent to the wall, and the mass adherent to the wall, if it is more than 1 centimeter in diameter, and think of malignancy. But there are a lot of differential diagnoses for a polyp inside the gallbladder. The most common is the cholesterol polyp, and then there is adenoma, and there is carcinoma, there is adenomyomatosis of the gallbladder, metastasis to the gallbladder if there is a non-primary malignancy. Then if the lesion is more than 1 centimeter, you think of malignancy, especially if the wall adjacent to the lesion is thickened. Then consider gallbladder carcinoma as the first possibility for a mass inside the gallbladder which is more than 1 centimeter in diameter. ايوه 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 تمام. Okay, and what do you prefer? The most common. Carcinoma أكتر. Then always think of carcinoma as the most common gastric malignancy. And in cases of Leiomyositis plastica, the carcinoma can do this, and lymphoma also can do this, pancreatitis can do this, and some Crohn's disease and atrophic gastritis. A lot of conditions may lead to Leiomyositis plastica, but the most common cause of Leiomyositis plastica is carcinoma of the stomach. Then whenever you are asked about other possibilities, then you may say lymphoma and granulomatous disease and so on. But the most common cause of gastric malignancies is the carcinoma.
It's better to be reported as carcinoma?
Yes, you should. No, you should say that this is gastric carcinoma. Then they have a biopsy by endoscope, and you reach the final diagnosis. نعم. بس this depends on the timing. If you image the esophagus while the bolus is passing, then the esophagus will be dilated. Okay. Axial CT, abdomen with contrast.
Leading undercapsular spleen.
Subcapsular hematoma of the spleen. Okay, and there is a hypodense collection along the lateral splenic border. And there is also some fluid in the peritoneum along the surface of the liver, but you cannot see laceration in the spleen and you cannot see laceration in the liver. Then, whenever you see this and you want to know the bleeder, you look to the density of the blood adjacent to both organs, and here the density is more than the density adjacent to the liver, and this is known as the sentinel clot sign. The sentinel clot sign indicates that the spleen is the bleeder. Then this is the subcapsular hematoma in the spleen and the hemoperitoneum. أيوة. X-ray, Belen UT, X-ray of the abdomen and the pelvis. Normal. Then where is the abnormality? Gallbladder. What's wrong with the gallbladder? Air in the wall of the gallbladder, and this is diagnostic of emphysematous cholecystitis, which is a fulminating inflammatory process in the gallbladder, which is commonly seen in diabetics. Very good. Sorry. Look here. This is the rim of the air in the wall of the gallbladder, and we said that three main issues can be diagnosed from the plain film considering the gallbladder. Number one, radio-opaque gallbladder stones. Number two, calcification of the wall of the gallbladder. Number three, the presence of air in the gallbladder wall, which is diagnostic of emphysematous cholecystitis. Yes, non-enhanced CT scan of the abdomen. Good.
One is hypodense with calcification in the wall. Left-sided.
Yeah.
Most probably splenic.
Okay.
And the other lesions.
This lesion, okay, in the gallbladder. This is the gallbladder. Okay.
There is a splenic hydatid cyst.
Yeah.
The gallbladder.
And gallbladder. Acute cholecystitis. Okay, then this is a non-contrast CT scan of the abdomen showing a big cystic lesion in the spleen, showing marginal calcification, suggestive of hydatid cyst, and the gallbladder shows diffuse mural thickening with no internal radiopaque calculi, and this is suggestive of acalcular cholecystitis. You remember that the cyst in the spleen can show calcium without being a hydatid cyst, but consider a calcified wall of a cystic lesion in the spleen or in the liver to diagnose the possibility of hydatid, especially in the liver. But you should remember that other cysts in the spleen can show marginal calcification. No, and if you feel this, then you should go to the spleen. If you feel that the density of the liver is higher, then you go to the spleen. If they look similar, then no problem. And this is a asymptomatic patient. For CABG is prepared to do an open heart surgery, and this is a CT scan of the abdomen after intravenous contrast injection. What do you think? Yes, and this is mesenteric panniculitis. Mesenteric panniculitis is an inflammatory condition which commonly is asymptomatic, and nowadays we see a lot of cases of mesenteric panniculitis, a lot of cases in patients doing CT scan of the abdomen looking for stones in the urinary tract. And many of these patients, they are not complaining of anything regarding this disease, which is diagnosed by the presence of an opacity or a stranding of the fat in the mesentery with a fat halo sign around the mesenteric vessels. And this situation may lead to acute abdominal pain, but many times it is asymptomatic, and this is mesenteric panniculitis. Yes. Okay. Baleen X-ray of the abdomen and the pelvis showing
calcification of the pancreatic area.
Anyone? Chronic pancreatitis, and this is calcium in the region of the pancreas, and this is diagnostic of chronic pancreatitis. Okay, and this is CT of the abdomen at the liver of the river after oral and intravenous contrast injection showing a big cystic lesion in the part in the left lobe and part in the right lobe. And this lesion contains internal septations of variable thickness and enhancement, and this is not fit with the hydatid disease. No, and this is me. Okay, and this is biliary cystadenocarcinoma. Biliary cystadenoma and cystadenocarcinoma are big cystic lesions in the liver. They may contain internal septations and calcium, and the difference between cystadenoma and the cystadenocarcinoma is the presence of thick internal septations or even mural nodules. And yes, and if you see a septum like this, and you consider this is one of the suggestive criteria of malignancy, both lesions should be removed. Cystadenoma should be removed because of the potential to turn malignant. Then if you even say that this is cystadenoma, it may be considered a good answer.
And the axial CT of the abdomen after contrast enhancement, في laceration at the level of the spleen, مع hematoma outside it.
بس yes, and this is the contrast enhanced CT scan of the abdomen, and you see a deep laceration in the spleen, perisplenic hematoma, and hemoperitoneum. The liver is intact. There is no laceration in the liver, but this is grade 3 laceration of the spleen, and perisplenic hematoma and hemoperitoneum. This one, we need to see other sections to be sure that this is a fracture or not. And the ribs, these ribs, okay, maybe also affected in trauma. It's a pregnant female, and she suffered the motor vehicle accident. There may be some fractures here, and this may be also a fracture, but we need to have some other sections to be sure. مين اللي عليه الدور؟
Axial CT contrast.
Axial CT scan of the abdomen with intravenous contrast.
Irregular wall, hypotense, to mass lesions in the liver, with contrast in the periphery, mostly hemangioma.
Okay. And this is a big cystic lesion in the liver, affecting part of the left lobe and part of the right lobe. The lesion showed peripheral nodular contrast enhancement, which is the typical pattern of a hemangioma. And this hemangioma is big, more than 6 centimeters in diameter, and is considered giant hepatic hemangioma.
Of the abdomen, axial cut with IV contrast.
قول. Yes, so where is the lesion? In which organ? Mean? Pharyngium. Okay. Yes, and this is a contrast enhanced CT scan of the abdomen, and you see air corresponding to the site of the body and the tail of the pancreas, associated with some fluid density around the affected part of the pancreas, reaching the this area is known as the lateroconal space, or the lienorenal space, the space between the spleen and the kidney. And this is the kidney, which is surrounded by the gerotophagia. Then whenever you see air in the pancreas, and this means that it is emphysematous pancreatitis or necrotizing pancreatitis, which is a severe fulminating complication of acute pancreatitis. And you may say also that this is gangrene of the pancreas. This is fat, and this is the fat which is normally located around the kidneys, and the fat is surrounded by the gerotophagia, which separates the collection from the kidney itself. And this was, of course, here in the stomach.
Abdominal exercity with IV contrast
أيوة.
and hypotonicity the lesion in the liver with peripheral nodal enhancement.
Yeah.
Most likely giant hemangioma.
Giant hemangioma. And this is contrast enhanced CT scan of the abdomen at the level of the liver, showing a big cystic lesion in the involving most of the hepatic parenchyma, showing nodular enhancement of the margin as well as some of the internal septations, and this is diagnostic of giant hepatic hemangioma. انت كل حاجتك بلين اكس راي.
Showing clearing effect occupying the stomach.
Okay. Very good. And this is an X-ray of the abdomen showing a big lesion in the stomach of mottled density with air loculi within the confinement of the lesion, and this is classic for gastric bezoar, meaning that this is a foreign body in the stomach, and there are 3 types of gastric bezoar. Trichobezoar made of hair, phytobezoar made of some food, and the pharmacobezoar made of medications, and other many types of unnamed bezoars. The classic appearance of bezoar is the presence of air within the meshes of the mass, and if you move the patient, this bezoar will also be mobile. Because here you cannot see the wall of the bowel, and here actually in this area you see the wall of the bowel, and there should be in the history something to encourage you to diagnose pneumoperitoneum. And there are 2 main conditions for the pneumoperitoneum: recent surgery and the trauma. Then if there is no yes, okay, CT abdomen,
axial cut with the IV contrast,
axial cut with IV contrast,
showing circular cystic lesion with floating shadow.
yeah, hydatid cyst. And this is a typical appearance of hydatid cyst anywhere in the body. A cystic lesion which is here located in the left lobe of the liver with internal floating shadows, diagnostic of hepatic hydatid cyst. Axial CT, triphasic. Yes, the spleen is big. With multiple focal lesions in the spleen, and the lesions are solid or cystic? Solid. Then the diagnosis will be lymphoma, and you see bulky lymph nodes here anterior to the IVC. Then solid lesions in the spleen with lymph nodes, or even without lymph nodes, and you think of splenic lymphoma. Okay.
CT scan, axial CT after IV contrast.
Okay.
showing focal lesion in the left tube of the liver,
تمام.
most probably hepatocellular carcinoma.
Very good. And this is a CT scan of the abdomen after oral and intravenous contrast media administration, showing the cirrhotic configuration of the liver with lobulated outline. And there is an ill-defined lesion in the lateral segment of the left hepatic lobe, the segment number 2. And the lesion showed heterogeneous post-contrast enhancement. It is solid. And the most common solid lesion in the cirrhotic liver is the hepatocellular carcinoma.
Axel CT was contrast,
أيوة.
oral and IV.
مم.
So well-defined lesion. Peritoneum. يكون برضه فين الكوكوين.
This lesion, then, and this is the gallbladder, and this is post-contrast CT scan of the abdomen after intravenous and oral contrast material administration. The gallbladder is distended, and the wall is thick, and inside the wall you see multiple cystic lesions inside the wall, and this is no, this is not adenomyomatosis. This is dense granulomatous by cholecystitis. And dense granulomatous cholecystitis is diagnosed by thickened wall with internal septations within the wall, and maybe you may see mass in the gallbladder itself. One of the suggestive criteria of densogranulomatous cholecystitis is the presence of inflammatory changes in the adjacent liver parenchyma. And this, in my opinion, may differentiate densogranulomatous from adenomyomatosis. Adenomyomatosis is not an inflammatory condition and is characterized by polyps inside the gallbladder, thickened gallbladder wall, and also the thickened gallbladder wall may contain cystic changes. But according to the literature, you cannot separate densogranulomatous cholecystitis sometimes from carcinoma of the gallbladder. Both are almost exactly similar whenever you see a mass inside the gallbladder. But this appearance is almost diagnostic of densogranulomatous cholecystitis whenever you see that the gallbladder wall is thickened and you see internal cystic changes within the gallbladder wall. Yes, and this is a CT scan of the abdomen after oral and intravenous contrast material. Yeah. Okay. Then the small bowel loops are dilated. Then you got multiple air fluid levels, and you see air in the wall of the bowel, and also you see air in the portal venous radicals, and this is diagnostic of mesenteric ischemia or intestinal ischemia. Whenever you see air in the wall, and this is ischemic bowel, and even proceeding to gangrene, especially if you see air in the portal vein. Air in the portal vein is a very bad sign. And this means that the patient is about to die, And you can see air in the wall, meaning gangrenous bowel, air in the portal vein, and this is part of the colon. This is the gallbladder with no air inside the gallbladder, and this is mesenteric ischemia. Pneumatosis intestinalis, if it is present in the colon, this is a benign condition and is not life-threatening. But if you see air in the wall of the small bowel, this is dangerous. In the children, is diagnostic of necrotizing enterocolitis, and if in the adults, is diagnostic of mesenteric ischemia. مين اللي عليه الدور؟ اتفضل. Contrast enhanced CT scan of the abdomen and pelvis of the abdomen. Okay, there is some thickening of the wall of the stomach. Okay, and it's a big mass in the peritoneum. Yes, neoplastic of the diagnosis is gastric carcinoma. Okay, if you look to the scan and you see that the gastric wall, this is the gastric wall which is enhancing, and this is the gastric lumen. The stomach as well as the adjacent area are involved by this very big mass of relatively hypodensity, and this mass classically indents the surface of the liver. And we said that if you see a lesion in the peritoneum that is causing a scalloping of the surface of the liver or scalloping of the surface of the spleen, and you think of pseudomyxoma peritonei. And this pseudomyxoma peritonei may be of benign etiology and may be of malignant etiology. Benign lesions producing mucin, like the gallbladder or the appendix, may involve the peritoneum like this. And malignant lesions may also, like adenocarcinoma, mucinous adenocarcinoma, and other tumors may produce mucin material in the peritoneal cavity. And the best diagnostic clue is the scalloping of the surface of the liver and the scalloping of the surface of the spleen. Yeah. Yes, and we always search in the abdomen, but usually we fail to see the exact pathology, and we may have biopsy from this lesion that can help us. Yes, the ovary and the colon are the most common lesions that can do so. Okay. Yes. Yeah.
Thickening of mucosa of the stomach wall.
Yes. Mm-hmm.
هو هنا متاخد تانجنشن يعني في الوول، فعشان كده اليومن مش باين، ولا هو توتالي اوكلودد
and it looks like it is totally occluded, but you cannot see this is part of the fundus of the stomach, and you see marked thickening of the wall, almost obliterating the gastric lumen in the region of the body and extending to the pyloric canal. And then there is some patency here in the pyloric canal. Then what do you think? Yes, or okay. Yes, lymphoma can encroach and totally narrow the lumen, and it does not usually produce gastric outlet obstruction, but it can encroach on the lumen, and it can present as Lionitis plastica. The lumen is markedly reduced. Okay. Axial CT on the abdomen. Yes, cystic lesion in the posterior segment of the right hepatic lobe. Thick wall. Abscess. Okay. This is CT scan of the abdomen after oral and intravenous contrast injection showing a cystic lesion in the posterior segment of the liver, and this lesion showing marginal enhancement with perilegional halo of edema, which is characteristic of the hepatic abscess. Then there are two types of hepatic abscesses, pyogenic and amoebic, and we cannot separate between both by any means. Okay. أيوه. Axial CT abdomen. This is MRI of the abdomen, T1 weighted image with contrast. Yeah, this is MRI of the abdomen, T1 weighted images with contrast because of the enhancing renal parenchyma. Then you see that the liver is black and the spleen is mottled. Then what do you think? Hemo? And hemo? Okay. Then if you see black spots in the spleen, and this is known as Gandhi bodies, and they are sidrotic nodules made of iron, so that they appear black in the MR images. They are especially seen very clear in the T1 weighted images, especially if you inject the contrast material, and they see that the liver is black compared to the muscle, meaning that there is an iron overload also within the liver parenchyma.
T2 MRI, axial T2 MRI.
Yes, axial T2 MRI of the abdomen.
There is multiple cystic lesions in the spleen.
Actually, these are the kidneys. There are multiple cystic lesions in the kidneys. Yes, polycystic disease. Then this is the kidney, and this is the kidney, and there are some cystic lesions in the liver, and this is polycystic disease. Yes. Okay. تفضل. Yes.
multiple hepatic focal hypotensive hepatic focal lesions, and there is also portal lymphadenopathy within para-aortic lymph nodes.
Okay.
Splenic focal lesion.
Splenic focal lesion.
Likely lymphoma.
Lymphoma. Okay, and they forgot this lesion, which is located in the adrenal gland. Okay. Then this is post-contrast CT scan of the abdomen after oral and intravenous contrast injection showing multiple relatively hypodense hepatic focal lesions, hypodense splenic focal lesion, and some lymphadenopathy around the superior mesenteric artery, as well as mass in the left suprarenal gland. And based on the splenic focal lesion, which is solid, and the most common solid lesion in the spleen is the lymphoma, then he diagnosed that this is lymphoma of the spleen, liver, nodes, and the adrenal gland. Cholangiocarcinoma. Time. Okay, and this is a CT scan of the abdomen after intravenous contrast administration. There is no oral contrast, and showing that the liver contains multiple focal lesions. These are not dilated biliary radicals because they are no, they are not tubular and not cystic dilated biliary radicals. There are many focal lesions in the liver. Then if you look carefully at this region, which is the region of the pancreatic body, and you see a mass which looks like partially cystic and partially solid, and masses in the pancreas should be considered malignant, and then you can be able to explain the presence of focal lesions in the liver as metastatic deposits. And this is pancreatic carcinoma with metastatic disease in the liver. Then this is the aorta, and this is the region of the superior mesenteric artery, which may be encased by the tumor.
CT with the contrast, IV and oral,
Yeah.
and the pre-dilated intrahepatic biliary radical,
Yeah.
and the well-defined hypodense lesion موجود عند الدوم of the liver.
Yeah. Okay.
Retraction carcinoma, hepatic cholangiocarcinoma.
Okay. And this is the right answer. This is the CT scan of the abdomen after oral and intravenous contrast media administration, showing a focal lesion in the liver near the hepatic dome, affecting part of the left lobe, and there is associated dilatation of the intrahepatic biliary radicals as well as the retraction of the hepatic capsule, and these criteria are suggestive of intrahepatic cholangiocarcinoma.
دكتور IPCP
No, then this is flow. If you inject the flow rapidly, then you got a mixture between non-opacified blood and the opacified blood.
axial CT
Yeah.
contrast.
Okay.
في thick wall cystic lesions
Yeah.
right loop of liver,
Yes.
mostly abscess.
Good. And this is the contrast enhanced CT scan of the abdomen after oral and intravenous contrast media administration, showing a cystic lesion in the right hepatic lobe, and this is segment 7. The lesion showed thick enhancing margin with some hypodense halo around, and also you got some pleural reaction bilaterally, and this is hepatic abscess.
CT of the chest with all the contrast.
Yes, contrast enhanced CT scan of the chest. then there is a mass here, posterior to the trachea. And this air represents the esophagus. Then you see a mass in the mediastinum, which is posterior to the trachea, with a linear air hypodensity representing the esophageal lumen, meaning that this lesion is arising from the esophagus. Then what do you think? Esophageal carcinoma or lymphoma. They cannot separate esophageal carcinoma from lymphoma of the esophagus by imaging, but carcinoma is far more common than the lymphoma in the stomach and in the esophagus. But if you see a lesion that is long, affecting a big segment or long segment of the esophagus, then you think of lymphoma, because carcinoma is usually localized lesion, but lymphoma is an extended lesion. And this is the only situation. But if you have a section like this or two, and you see a mass with the esophagus in the center of the mass, it should not be exactly in the center, maybe like this one, somewhat peripherally located, and you consider this is lymphoma or carcinoma. But if the esophageal lumen is stretched along the outer margin of the lesion, and this is leiomyoma. Okay. ERCB. 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 Okay, and this is the common bile duct, which is normal in caliber, and intrahepatic biliary radicals are also good. The abnormality is here, and there is cystic dilatation of the distal part of the common bile duct, and this is known as cholodococele, which is similar to the erythrocele. One type of the colodocal cysts, the third one, the third type of colodocal cyst is cholodococele. No, this is just superimposition of the ducts. Superimposition of the ducts. Or maybe sometimes you got the dilatation of the intra and the extrahepatic biliary, maybe. Axial CT scan of the abdomen after oral and intravenous contrast material administration, showing a huge cystic lesion occupying a good part of the liver, with some calcific foci and internal septations. Hydatid cyst. Biliary cyst adenoma. Then if you look carefully around the lesion, and you got some dilatation of the intrahepatic biliary radicals, which is one of the supportive criteria of this lesion to be biliary cyst adenoma. I have mentioned that biliary cyst adenoma is a big cyst in the liver with internal septations, maybe calcification of the septi or the wall of the lesion. One of the leading criteria for the diagnosis is the presence of some dilatation of the biliary radicals around the lesion. Yes.
Showing a focal lesion, multiple focal lesion.
Multiple.
Focal lesion enhancing in the arterial phase.
And this is the only lesion which is enhancing in the arterial phase. And you consider these as portal venous radicals because they appeared in the portal phase. then you are left with a single focal.
focal lesion enhancing in the arterial phase.
أيوة
differential diagnosis.
أيوة
هو كل واخد صبغة فممكن نقول عليه فلاش منجومة أو focal
مش راضيين. HCC
ال HCC بيبقى heterogeneous enhancement.
أيوة. مين الوحيد
اللي بقى focal nodular.
and yes, and this is the contrast enhanced CT scan of the abdomen arterial phase and portal phase. Yes, many times it looks like the cut surface of the orange, but sometimes it does not. And one of the important criteria of focal nodular hyperplasia is the strong arterial homogeneous enhancement. Sometimes you got a central scar inside the lesion which will help you in reaching the diagnosis. But also one of the best diagnostic rules for this particular lesion is the total absence of the lesion in the portal phase. Because this lesion is hypervascular, it will enhance strongly in the arterial phase and you can miss the lesion in the portal phase. But sometimes you can see also the lesion in the portal phase and you can see the central scar, which is helpful in the diagnosis. Also, one of the possibilities is the hepatocellular adenoma, which is also a hypervascular lesion, and it can disappear in the portal phase. Yes, in the hepatocellular carcinoma, it enhances strongly in the arterial phase, but the evacuation in the portal phase will lead to see the tumor itself and the capsule if it is present. But the lesion like this is this is arterial and this is portal. Yes, these are the arteries, branches of the hepatic artery, and the IVC is not yet opacified. Okay, and also you see that the liver is not cirrhotic, and there is an incidence of HCC in a non-cirrhotic liver, but consider this lesion whenever it enhances homogeneously and strongly as a focal nodular hyperplasia. Barium swallow. Yes, and there is a severe irregularity of the distal part of the esophagus. Esophageal carcinoma. This is barium swallow showing marked irregularity of the distal segment of the esophagus with luminal narrowing and mucosal destruction, and this may suggest carcinoma and lymphoma, and you consider carcinoma as a first possibility. Then if you see this barium which is coming out of the esophagus to the pleural cavity, and if you have a large film to see the rest of the chest wall, then you can see barium in the pleura, meaning that you got a fistula between the pleura and the esophagus, which is seen in some cases of esophageal carcinoma whenever invading the lung or the pleura. In this case is present in the artery. Okay.